Okay, who is the first presenter? Ishwar? Dr. Ishwar is not here. First presenter is not here. Who is the second presenter? Dr. Monica? Are you ready with your presentation? Come on. Come to your dais.
Shall I start? Good, good morning everyone. I'm Dr. Monica from NRIMS Vishakhapatnam. Today's my presentation is Pregnancy-Induced Central Retinal Vein Occlusion Non-Ischemic, a rare case report. CRVO occurs during normal pregnancy, preeclampsia, eclampsia or postpartum period. Hypercoagulability with increasing clotting factors, particularly 8, 9, 10 fibrinogen levels and decrease in antithrombin 3 and protein C and S are important. Pregnancy alters the balance within the coagulation system in favor of hypercoagulability, predisposing the pregnant and postpartum women to retinal venous thrombosis. Even though preeclampsia and eclampsia during pregnancy is associated with significantly higher incidence of CRVO, it is rare to see thromboembolic phenomenon in normal pregnancy. Case report, a 21-year-old female from Vishakhapatnam came with a chief complaint of right eye blurring of vision since 2 days. History of presenting illness, patient came with a complaint of blurring of vision right eye since 2 days, sudden in onset, no history of diabetes mellitus, hypertension, headache, vomiting, fever, cough, breathlessness, chest pain, sleep apnea, no signs of preeclampsia or eclampsia, no history of usage of OC pills, recurrent nosebleeds or increased menstrual blood flow, no history of pain, swelling in legs, no history of blood transfusions or easy bruising, no history of usage of any systemic medications. Obstetric history, she is primary gravida of 40 weeks of gestation with oligohydramnios. Past history, no history of similar complaints in the past. Personal history is nil significant. Family history, no significant family history. General examination is within normal limits. Vitals are within normal range. Systemic examination, perabdomen, gravid uterus present, CVS, respiratory and CNS examination were within normal limits. Local examination, head posture, facial symmetry, ocular movements or orbital margins are within normal limits. Ocular examination, right eye visual acuity is 612, improving to 6.9. Near vision is 6 and 6. Remaining anterior segment findings are within normal limits. Left eye visual acuity is 6/6. Remaining anterior segment findings are within normal limits. Fundus examination, right eye, media, coarse vitreous floaters present, intravitreal hemorrhage present at macular area, optic disc superficial hemorrhages present in superior margin of the optic disc with multiple peripapillary intraretinal hemorrhages, preretinal hemorrhage present at superotemporal to the disc, AV ratio 2:4, venous engorgement is present, FR dull macular edema is present. Peripheral retina soft X-ray is present superior to the disc, rod spots are present. Fundus examination, left eye, media is clear, optic disc size, shape, color is normal, cup disc ratio 0.3:1, vessels AV ratio 2:3, macula FR plus and peripheral retina is normal. OCT macula of right eye shows increase in macular thickness. B scan of right eye shows intravitreal hemorrhage. Hematological investigation where hemoglobin, hematocrit, MCH were decreased and eosinophils, APTT, prothrombin time and INR are within normal limits. RBS and creatinine is within normal limits. Coagulation profile where fibrinogen and factor VIII were increased and protein S was decreased. Provisional diagnosis, right eye pregnancy induces central retinal vein occlusion, non-ischemic, resolving stage secondary to hypercoagulable state. Postpartum evaluation, patient underwent elective LSES, 5 days postpartum patient evaluated in ophthalmology OPD where ocular examination visual acuity improved to 6/6. Fundus examination, right eye 5 days postpartum where media is clear, optic disc resolving intraretinal hemorrhages superior to the disc, total resolution of peripapillary hemorrhages, cup disc ratio 0.3:1, vessels AV ratio 2:4 and venous engorgement present, FR plus and peripheral retina is normal. OCT macula 5 days postpartum, it is a normal study. Fundus examination, left eye, media is clear, optic disc size, shape, color is normal, cup disc ratio 0.3:1, vessels normal, FR plus and peripheral retina is normal. Coming to discussion, incidence of CRVO commonly seen in pregnancy associated with preeclampsia and eclampsia. It is rare to see CRVO in normal pregnancy, as we have noticed in the present case report. Normal pregnancy is considered as a risk factor for CRVO due to hypercoagulable state, and incidence of venous thromboembolism during pregnancy is 6 times greater than non-pregnant women. The effects of progesterone on blood vessel walls results in venous stasis, leading to CRVO even during normal pregnancy. To conclude, this case highlights the incidence of central retinal vein occlusion in normal pregnancy without associated preeclampsia or eclampsia. Evaluation of all pregnant women in third trimester and postpartum period for hypercoagulability and exclusion of inherited thrombophilia will help us to diagnose retinal venous occlusions and management of related complications. Thank you.
Presentation. What type of CRVO was that?
Non-ischemic CRVO, ma'am.
So the result was quite fast. Within 5 days of postpartum, did that improve? There was no hemorrhage at all, no?
Yes, sir. Yes, ma'am. It is improved, ma'am.
Thank you.
Thank you.
What will be the next important issue if it is patient general condition or patient eye condition? What you give more importance? What you give more importance, whether to the patient general condition or regarding the eye? What you will prefer to treat in this condition?
In this case, we will treat general condition of the patient initially, sir. Later, we will go to eye.
Yes, as we have to go to this. And regarding the general condition findings, 40 weeks primary gravida, she can't have that apparently normal findings.
Yes,
okay.
sir.
And good
Thank
presentation.
Yeah, next Dr. Shivani. Come.
Good morning, everyone. I'm here to present a case series of retinitis pigmentosa with ocular and systemic associations. Firstly, retinitis pigmentosa is a group of hereditary disorders of the photoreceptors and retinal pigment epithelium, which gradually cause night blindness and progressive constriction of the visual fields. Waxy pallor of the optic disc and arteriolar narrowing are found in almost all of the cases. Pigmentary changes are usually seen, but may be absent or mild early in the course of the disease. The pigmentary changes seen are characteristic of bony spicules, diffuse granularity or stippling, and pigment clumping. These are due to photoreceptors degeneration, atrophy in the outer retina and pigment epithelium, and RPE cells migrating into the retina. The photoreceptor and RPE function loss progresses posteriorly and can lead to loss of visual acuity from involvement of the macula and constriction of the visual field. It can be found in isolation, where it is referred to as non-syndromic RP, or in association with a variety of systemic diseases where it's referred to as syndromic RP. My aim of the study was to study the various manifestations of retinitis pigmentosa and to study the various ocular and systemic associations of retinitis pigmentosa. This is basically a case series of 18 cases of retinitis pigmentosa. Institutional Ethics Committee approval was obtained. This study was conducted over a period of 1 year. A brief history was obtained, which was followed by visual acuity assessment, complete ocular examination, direct and indirect ophthalmoscopic examination, fundus photography, evaluation of various systemic associations, and other specialty evaluations were advised when required. Coming to the results, most of the cases were in the age group of 15 to 30 years, while 5 cases were less than 15 years and 3 were more than 30 years. And there were 13 males and 5 females. Most of the cases had a vision better than 660, 11 cases, while 7 of them had a vision less than 660. The most common anterior segment finding that I found was posterior subcapsular cataract, and 4 of them were already operated, so pseudophakic patients, and 5 were normal patients, while 1 we found keratoconus. And coming to the posterior segment findings, we found pigmentary bony spicules in all the 18 cases. In 14 of them, the pigmentary spicules were present involving the mid-periphery and beyond, while in 4 of them there was central and patchy distribution. Consecutive optic atrophy was present in 8 patients, maculopathy in 6, cystoid macular edema in 1 patient, myopic changes in 5, glaucomatous changes in 2, and in 1 patient we saw that there was coloboma. This is a bar representing the same. The top images are showing a typical retinitis pigmentosa associated with maculopathy. The bottom images are also showing retinitis pigmentosa. These images are showing atypical retinitis pigmentosa. Here we can see some tessellations and pigment distribution. This is an OCT that is showing CME that we found in one patient. And the most common systemic association that we found was sensorineural hearing loss in 4 patients, heart block in 1 patient, polydactyly and truncal obesity in 1 patient, and alopecia was present incidentally in 1 patient. This is a bar representing the same. Retinitis pigmentosa refers to a group of hereditary retinopathies that result in progressive vision loss. Prevalence of RP is around 1 to 3,000 to 5,000. In this study, we have come across 18 cases of retinitis pigmentosa, of which around 80% of them had ocular associations, while only 40% of them had systemic associations. Natarajan et al. Has reported that around 50% of patients develop posterior subcapsular cataract, cause of which has been subjected to be low-grade ocular inflammation. In this study, we have found posterior subcapsular cataract in 45% of the patients, and 20% of them have already been operated. Natarajan et al. Has also reported that there is a higher prevalence of myopia and astigmatism in RP patients. In this study, we have noted myopic changes in 25% of the patients. Joanne D. Arias et al. Reported prevalence of macular edema in RP to be around 8 to 50%, cause of which has been hypothesized to be breakdown of blood retinal barrier. In this study, we have found macular edema in 5% of the patients. Other ocular associations that we noted were keratoconus and glaucomatous changes. In a study done by RP Mills and DM Calver on 17 patients, they found 6 patients of Usher syndrome. In this study, we have noted sensorineural hearing loss in 4 patients. Other systemic associations that we found were polydactyly and truncal obesity in 1 patient and heart block in 1 patient. Coming to my conclusion, in conclusion, our study confirms the retinal associations in the previous studies and also adds to the existing literature. Patients of RP present with nyctalopia and progressive constriction of the visual fields. Visual acuity is usually affected late but can be affected early due to PSCC, cystoid macular edema, and foveal atrophy. ERG becomes abnormal very early in the disease and hence aids in the diagnosis. Perimetry, fluorescent angiography, and OCT are advised when necessary. Low vision aids are useful to these patients. Gene therapy, stem cell therapy, and retinal implants are the other treatment modalities available. Thank you.
Okay. So what is the most common mode of inheritance?
It is sporadic inheritance. Sporadic, ma'am. If it is inherited, autosomal dominant variety is more common.
Which type of inheritance is most severe in its presentation?
X-linked recessive is more severe.
Thank you.
You've shown that fundus findings of some patients are having the myopic changes,
Yes,
macular edema,
yes,
and
sir.
other things. What do you address to those kinds?
We'll advise if there is cystoid macular edema, advise necessary treatment to those patients, sir.
What treatment can you advise?
Intravitreal injections.
Intravitreal injections usually won't work because it is not due to the vascular pathology.
Yes, sir.
For macular edema, it is due to the RP pump failure.
RP pump failure.
So
Yes, sir.
there is no proper treatment. It is not and stem cell therapy, gene therapy are still
Emerging modalities.
controversial also.
Yes, sir.
Nice presentation. Thank you.
Thank you, sir.
What is the percentage of consecutive optic atrophy?
We found in 8 patients that we saw, sir.
How can
Out
it,
of
how
18.
can it be possible? So it will be there in everybody, no?
Yes, sir, but in like complete waxy pale, I mean the total optic atrophy that we saw with
How
the
can you
vision
grade?
drop.
It is total optic atrophy or partial optic atrophy. So if you are mentioning optic atrophy, it will be 100%. So every patient will have optic atrophy.
Okay,
So you have waxy pallor disc in
yes,
every
sir.
patient. No?
Yes, sir. Okay, sir. Thank you, sir.
Yeah, next, Dr. Kalpana.
Good morning one and all. Myself Dr. Kalpana, second year postgraduate from SV Medical College Tirupati, and today my topic is bilateral exudative retinal detachment in a preeclampsia patient. Introduction. So preeclampsia is a multi-system disease occurring in 3 to 5% of the pregnancies in third trimester, classically characterized by new onset of high blood pressure, with systolic more than or equals to 140 mmHg and diastolic more than or equals to 90 mmHg, along with high blood pressure. Other signs and symptoms include proteinuria, decreased platelet count, increased liver enzymes, nausea and vomiting, blurred vision, severe headaches and shortness of breath. If left untreated, preeclampsia may lead to serious and even fatal complications for both mother and baby. So common ocular manifestations of preeclampsia is blurred vision. Others include headache, photopsia, visual field defects, and in severe cases complete blindness. So focal or generalized arteriolar narrowing is the common finding, and exudative retinal detachment may occur in 1% of the patients with preeclampsia. A case report: 21-year-old primee of 32 weeks gestational age with imminent eclampsia had preterm normal vaginal delivery. Her blood pressure recording initially was 140 by 100 mmHg, which was controlled with medication, and later it was not more than 120 by 80 mmHg. She was referred to ophthalmic OPD with chief complaints of sudden onset of blurred vision associated with severe headaches. On examination, her best corrected visual acuity was 6 by 60 in right eye and counting fingers close to face in left eye. Dilated fundus examination showed hyperemic disc with blurring of nasal margins, generalized arteriolar narrowing along with multiple subretinal exudates in general background, a large small detachment seen inferior to disc margin in left eye, suggestive of exudative retinal detachment with serous detachment of retina in both eyes. OCT imaging showed macular edema with serous detachment of retina in both eyes. This is the fundus picture of right and left eye, and OCT picture of right and left eye showing the serous detachment with increased macular thickness in both eyes. So strict control of hypertension was advised. Patient came for follow-up after 3 months and her best corrected visual acuity was improved to 6 by 9 in both eyes. Dilated fundus examination showed resolution of retinal detachment with few pigmentary changes of retinal pigment epithelium. So this is the follow-up picture of fundus picture and OCT picture of both eyes. So conclusion, this shows the importance of complete ophthalmic evaluation in a case of preeclampsia. Thank you.
Okay. At what time of gestation did the patient present to you?
32 weeks of
32
gestation.
weeks.
She had preterm delivery.
Okay. So they had to terminate the pregnancy.
Termination.
So can you tell me any other indications to terminate the pregnancy in a hypertensive point of view?
Eclampsia.
No, from ophthalmic point of view, when you want to decide that the patient had to be terminated, the pregnancy has to be terminated. Any other indications? One is serous retinal detachment you told. Any other ocular indication you want to tell? What are the other ocular manifestations of PIH?
Retinal detachment. CSCI.
Okay, thank you.
What might be the probable cause for the exudative detachment?
Sir?
What might be the probable cause for the exudative retinal detachment?
Sir, in preeclampsia there will be increase of vasoconstrictor agents which causes ischemia of choroid, which will damage to choriocapillaries, will affect the RPE. So there will be collection of subretinal fluid which caused might be.
Okay, if you don't
might be
terminate the pregnancy, does it have any outcome effect on the exudative artery?
Sir,
If we don't terminate the pregnancy, does it affect the ophthalmic condition of exudative artery?
no sir, actually strict control of hypertension will there is no need, yes, sir. It will cause better outcome. Thank you, sir.
Okay, Dr. Indulata.
Good morning, everyone. I'm Dr. K. Indulata, second year postgraduate from Karnool Medical College. My presentation today is case series of fundoscopic findings in patients with anemia. Anemia is a hematological disorder presenting with various ocular manifestations. Conjunctival pallor, retinal hemorrhages are the predominant features. Anemia occurs when the RBC or hemoglobin levels are below the normal. The cause of anemia may be due to defective production or excessive destruction of the RBCs. Retinal hemorrhages were first described at Ulrich in 1983. The risk of retinopathy increases with the severity of anemia, particularly when the hemoglobin levels fall below 6 gram per son. The ocular manifestations of anemia are dry eye, conjunctival hemorrhage, lid hematoma, orbital hemorrhage. Fundus changes include retinal hemorrhage, subhyaloid hemorrhage, central retinal vein occlusion, vitreous hemorrhage, optic disc edema, and optic neuropathy, macular edema, and rod spots. Thrombocytopenia will be associated with anemia in many situations, causing coagulation defects and hemorrhages. Coming to retinal changes in anemia, hemorrhages, dot blot hemorrhages occur in the deep retinal layer. Superficial hemorrhages occur in the nerve fiber layer, which is the most common finding in anemic retinopathy. Sometimes subhyaloid hemorrhages may also be present. Rarely vitreous hemorrhage can occur. Cotton wool spots occur due to retinal nerve fiber layer infarction. Vessel changes include arterial attenuation and dilated tortuous veins, which is seen in severe anemia cases. Rod spots are white-centered hemorrhages that result from retinal capillary rupture and extrusion of whole blood, followed by platelet adhesion to the damaged endothelium, initiating a coagulation cascade and forming of white lesion in the center of hemorrhage, which is a platelet fibrin thrombus. Hard exudates occurs due to leakage of lipoproteins from retinal capillaries in the outer plexiform layer. Optic nerve changes include edema, optic neuropathy, optic disc pallor in the later stages. This is a hospital-based cross-sectional study including 60 patients with anemia of various etiologies attending medicine, gynecology, and surgery departments. This study was done in Department of Ophthalmology in Karnool Medical College. Informed consent was taken from the patients. Complete hematological workup was done. Patients with diabetes and hypertension were excluded from this study. All the patients were examined for retinal manifestations in detail. Visual acuity of both eyes was documented using Snellen's chart, and anterior segment examination was done with torchlight followed by slit lamp biomicroscope. Posterior segment of eye was thoroughly examined for retinal hemorrhages, cotton wool spots, macular star or optic disc with the help of direct ophthalmoscope, and pictures were taken with the fundus camera. This study was conducted in 46 females and 14 males, and most common females were affected, accounting to 76.6% and males 23.3%. The most common finding was rod spots, which accounts to 66.6%, followed by fundal pallor, cotton wool spots, flame-shaped hemorrhages, dot blot hemorrhages, venous dilatation, tortuosity, macular edema, and preretinal hemorrhages. Most of the patients presented with moderate anemia, accounting to 41.6%. These are the pictures showing macular edema, boat-shaped hemorrhages, dot blot hemorrhages, superficial hemorrhages, and hard exudates. Ocular manifestations of anemias of various etiologies can result in different ocular manifestations. Nutritional anemia is the most common abnormality in India. It may be due to iron, folic acid, or vitamin B12. Iron deficiency is the most common type of nutritional anemia. Dr. Shitol Satish, Dr. Jakal Tapan P in their study reported maximum number of iron deficiency anemia among nutritional anemias. In our study, retinal hemorrhages were present in 78.3% of patients with severe anemia and 20.5% of patients with moderate anemia. The most common presentation were retinal hemorrhages, rod spots, and cotton wool spots. Retinopathy is a frequent finding in patients with severe anemia. Retinopathy was found in all patients with concomitant anemia and thrombocytopenia. Ophthalmic manifestations do not require any specific treatment other than controlling thrombocytopenia and anemia. Ocular symptoms can represent first sign of life-threatening systemic diseases like severe anemia, and thus facilitate timely diagnosis and treatment. Thorough examination of the eye with a suspicion of systemic diseases and control of disease will help improve retinopathy associated with severe anemia. Thank you.
Okay, good presentation, Amma. What do you think is the pathognomonic sign that we can say that it is due to anemia among all your findings?
Rod spots.
Yeah. Yes. Do we need to intervene? I mean, any ocular intervention is needed in these conditions?
Control of anemia is the main
is the main thing. At any point of time, can we intervene?
Macular edema.
If there is a very severe vitreous hemorrhage, do you want to intervene? Okay. Next, Dr. Sherin, Ishma Sherin.
Good morning everyone. My topic is study of orbital vessels by color Doppler imaging in diabetic patient without retinopathy. Diabetic retinopathy is a form of microangiopathy and is the most common ocular complication seen in diabetic patient. As life expectancy increases, the incidence also increases. Severity of hyperglycemia followed by duration of diabetes is the most important risk factors. Complications include diabetic macular edema, vitreous hemorrhage and fractional retinal detachment. Multiple methods are there to evaluate diabetic retinopathy, which include direct and indirect ophthalmoscopy. Other imaging modality like color fundus photography, fluorescein angiography, optical coherence tomography and B-scan ultrasound with color Doppler imaging. Coming to color fundus photography, it's useful tool to monitor for the improvement and progression of diabetic retinopathy, and easy to use, highly available and can be utilized to assist documentation, but we can't confirm clinically significant macular edema, and fine detail is often not apparent, and it can be difficult to obtain a good imaging if media is opaque. In case of FFA, it's gold standard to confirm the diagnosis of neovascularization in PDR, but like other contrast studies, there are side effects like transient nausea, vomiting and anaphylactic reaction. So coming to color Doppler imaging, it's safe, non-invasive and easily reproducible method for evaluating hemodynamic alteration in orbital and retinal vascular disease. Orbital vessels can be easily identified because of color Doppler shift is encoded in color and is superimposed on a two-dimensional grayscale ultrasound image. In this way, circulation of ophthalmic artery and central retinal artery can be investigated. Assessment of blood flow velocity, including peak systolic velocity, end diastolic velocity, and resistive index, is calculated for each retrobulbar vessels at the same time. Advantages include it can easily image ophthalmic artery and posterior ciliary artery as these vessels are inaccessible by fundus, FFA and laser Doppler velocimetry, and it can image central retinal artery if media is opaque, and morphologic and vascular information in various other ophthalmic diseases like hypertensive retinopathy, glaucoma, ocular ischemic syndrome and orbital tumors, and it's also useful in measuring the progression and severity of diabetic retinopathy, and it can also use it to dictate the flow velocity post-pan photocoagulation. Aim to evaluate the hemodynamic alteration in orbital vessels such as ophthalmic artery and central retinal artery, and to compare the peak systolic velocity and diastolic velocity and resistive index of ophthalmic artery and central retinal artery, and the color Doppler imaging in differentiating diabetic patient with and without diabetic retinopathy. What is resistive index? Is a measure of peripheral vascular resistance. It's not altered by angle of Doppler since it's a ratio, but Vmax and Vminimum is altered by angle of Doppler. So it's useful to measure to study the difference between various group of patients, and also we can avoid inter-observer bias. Resistive index is equal to P systolic velocity minus end diastolic velocity divided by P systolic velocity, and systolic by diastolic ratio is equal to P systolic velocity by end diastolic velocity. Materials and method. To evaluate, we evaluated 40 diabetic patients with 20 are with retinopathy and 20 without retinopathy with direct or indirect ophthalmoscopy, and we referred to radiology department. From the color Doppler evaluation was done, and Doppler spectral analysis of ophthalmic artery and central retinal artery were done. The peak systolic velocity and diastolic velocity resistive index were calculated. Inclusion criteria include patients with duration of disease from 2 to 15 years and diabetic patient with and without retinopathy. I included moderate, severe and very severe NPDR and PDR patients, and age group 39 to 73 years, and both sexes were included. Exclusion criteria is with patients with a history of congenital orbital pathology, trauma, infection, inflammatory lesions, benign and malignant lesions in orbit and cerebrovascular insult, hypertension, dyslipidemia, glaucoma, history of smoking, intake of drugs causing vasodilation. here after my observation, the resistive increase in case of control and diabetic retinopathy. Here the first case we can see the resistive index is increased. It's normal in diabetic retinopathy, but it's increased in with increase in case of patient with diabetic retinopathy, and we can see it's very much increase in case of patient with retina neovascularization. Result, resting index in central retina and ophthalmic artery of patient with diabetic retinopathy was clinically was significantly greater than without diabetic retinopathy. Clinical implication: hemodynamic changes can be picked early on color Doppler as compared to retinopathic changes, and it provides opportunity for early intervention and also prevent the need of photocoagulation. Conclusion: resistive index is used to assess the index of index in progression in diabetic retinopathy.
Okay, that was a new topic. Good. So, in what way do you think this is useful to us?
Actually, madam, with this color Doppler, we can find out this the hemodynamic changes will occur before retinopathic changes. So, we can early innervate in case of diabetic patients. And actually, these are seen in every vascular lesion. So, that's why in my exclusion criteria, I excluded diabetic, hypertension, dyslipidemia.
So, this will be useful in CRV, any vascular occlusions also.
Hemodynamic changes will occur earlier. So they will occur only after occlusion, no? They will occur only after occlusion.
No, sir. In case of atherosclerosis, and all, that resistance will increase more.
In diabetic, what is the pathogenesis?
In diabetes, then there will be
NPDR, for NPDR.
first in case of there will be chronic hyperglycemia, which causes aldol, reductive changes, and age-related
Ischemia is delayed relatively. Vaso-occlusion is next stage. Initially there will be
microaneurysm, which there will be pericyte loss, which cause pericyte death, which cause endothelial cell loss, which will cause hypoxemia, hypoxia.
those changes we cannot assess on Doppler, no?
And
In early stages.
no, this pericyte loss, everything is occurring because of this vascular changes, my friend. So, thank you.
In how many cases it was useful in detecting in your experience? In how many cases it has been useful for you in detecting early detection of any diabetic retinopathy or vasculitis? You told us that it detects early in diabetes or vasculitis cases. In your experience, how many cases did you find it useful?
It's increasing in everything, diabetic every chronic diseases, sir. So when I exclude a patient with only diabetic, like 18 patients, 6 increases, sir. Restive index is increasing. Thank you, sir.
Dr. Mansa?
Good morning, everyone. Myself Manasa from PSIMS, sir. Introduction. The term post-fever retinitis describes various retinal manifestations following systemic febrile illness, which can be due to bacteria, virus, or protozoa. Usually manifest within 2 to 4 weeks post-fever in immunocompetent patients, irrespective of etiology. It is either due to invasion by the pathogen or indirectly mediated through an immune-mediated mechanism. Empirical treatment targeting the causative organism consists of antibiotics, steroids, and intravitreal antivascular endothelial growth factors. Aim of the study is to study clinical features, optical coherence tomography findings, treatment options, and follow-up outcomes of post-fever retinitis. Materials and methods. Study type is prospective observational, and sample size is 10 patients and 19 eyes are involved. Study duration is 1 year, and study setting is Department of Ophthalmology, PSIMS or Kuppam. Inclusion criteria: patient diagnosed to have retinitis with recent history of febrile illness were included in the study. Exclusion criteria: herpetic and toxoplasma retinitis were excluded. Data collected on each patient include detailed history regarding onset of fever, associated rash, time of onset of ocular symptoms after febrile episode,
treatment received before presenting to us, best corrected visual acuity, which is converted to logMAR best corrected visual acuity, and central foveal thickness, fundus examination, and standard systemic investigations. Among the standard systemic investigation results, HIV, VDRL, and HPSAG results were negative in all the patients. Viral and dengue antibodies were positive in 6 and 4 cases respectively. The treatment protocol was individualized based on baseline clinical presentation, previous treatment received by the patient, and the clinical response of the patient. All patients are started on oral doxycycline 100 mg twice a day and intravenous steroid followed by oral steroid, IV 1 gram methyl prednisolone OD for 3 days, followed by oral prednisolone 1 mg per kg body weight. Maximum dose not exceeding 60 mg per day was initiated 5 to 7 days after starting oral doxycycline. 6 eyes which had severe macular edema more than 500 microns on initial presentation were treated with intravitreal antivascular endothelial growth factors, bevacizumab 0.05 ml to 1.25 mg per 0.1 ml, and oral doxycycline and oral steroids directly on the initial visit. All these 6 eyes showed positive response. Response is assessed at week 1, 2, 4 and 12 from the first day of initiation of treatment. At the end of 2 weeks, the following parameters were considered to assess the response: improvement in Snellen's best corrected visual acuity by at least 2 lines, reduction in size of retinitis lesions, and reduction in central macular thickness by more than 20%. Response was termed positive if at least 2 of the 3 above mentioned factors were seen. In case of positive response, tapering of steroids was done over 6 weeks and doxycycline was stopped over 4 weeks. In case of negative response with persistent of macular edema and steroids is continued and intravitreal anti-VEGF is given. Coming to results, a total of 19 eyes of 10 patients were enrolled, 60% 6 males and 4 females. The mean age group is 20 to 60 years. Counting fingers close to face and hand movements close to face were assigned the logMAR units of 1.85 and 2 respectively. The median baseline logMAR best corrected visual acuity was 1.30 with interquartile range of 0.8 to 1.8, and the median central foveal thickness was 423 microns with interquartile range of 182 to 555. Common fundus findings seen are whitish retinitis lesions seen in 100% of the cases, inflammatory retinal vessels in 89.5%, macular star in 15 eyes, and retinal hemorrhages in 12 eyes. OCT findings like neurosensory detachment in 15 eyes, intraretinal white dots in 12 eyes. On evaluating OCT features, 15.7%, 3 eyes, that is 3 eyes of patients had central foveal thickness less than 250 microns, and 10 eyes had central foveal thickness in the range of 250 to 500 microns, and 6 eyes had more than 500 microns. These are the fundus images showing the whitish retinitis lesions and the macular star, and OCT image showing the neurosensory detachment, and the scatter plot correlating the baseline best corrected visual acuity and the baseline central foveal thickness in microns, showing that higher the central foveal thickness was associated with poor best corrected visual acuity. Median best corrected visual acuity at the end of 12 weeks was 0.50. Attained Snellen's best corrected visual acuity of 6/12 or more, and 100% attained Snellen's visual acuity of 6/60 or more. At the end of 12 weeks, the median central foveal thickness was 223 microns, and there was a significant improvement in visual acuity and CFT overall. Discussion: the exact pathogenesis of post-fever retinitis is uncertain. Onset of ocular symptoms on an average of 4 weeks following an episode of fever, and inconclusive laboratory results in our study patients point towards a possible immunological basis in the pathophysiology. Role of anti-VEGF in post-fever retinitis is gaining importance as there is rise in VEGF levels in post-fever retinitis due to findings like vascular involvement and presence of severe macular edema and inflammatory new vessel formation. Anti-VEGF may help in faster resolution of macular edema and thereby improving the final visual acuity. Conclusion: this study provides valuable insights into clinical presentation, fundus examination findings, OCT findings, and treatment outcomes of post-fever retinitis. A combination of oral doxycycline and steroids as a treatment option showed improvement in best corrected visual acuity and central foveal thickness. Additional intravitreal antivascular endothelial growth factors help in faster visual recovery in patients presenting with severe macular edema at onset. Thank you.
Thank you.
What is the role of doxycycline and steroids in post-fever retinitis? Can you explain, elaborate?
Possible bacterial etiology. In case of, as an empirical treatment, we'll start on doxycycline for 4 weeks. Thank you.
Okay, Dr. Chandana.
Good morning, everyone. Today's my topic is central retinal thickness changes in pediat treated with intravitreal ranibizumab versus ranibizumab plus PRP. There are no financial disclosures. And coming to the intro, diabetic retinopathy is a common complication of type 2 diabetes and is the leading cause of blindness in the working population in the world. Without timely treatment, 50% of the patients with proliferative diabetic retinopathy will lose their sight within 5 years. Retinal neovascularization represents an important risk factor for the severe vision loss in patients with diabetic mellitus. Pan-retinal photocoagulation has been the gold standard for PDR treatment since the 1980s, as it arrests the progression of diabetic retinopathy by improving retinal oxygen supply and decreasing the subsequent production of vascular endothelial growth factors. Anti-VEGF and intravitreal therapies radically changed the outcome of the diabetic retinopathy due to combined anti-angiogenic and anti-edematous activities. Coming to the aim of my study, it is to compare central retinal thickness between the eyes with proliferative diabetic retinopathy treated with intravitreal ranibizumab and intravitreal ranibizumab with pan-retinal photocoagulation. Coming to my objectives, it is to assess the changes in central retinal thickness in patients with PDR undergoing intravitreal ranibizumab with PRP, and to compare both the groups. Coming to my study type, it's a prospective observational study with 30 eyes as a sample size, and they were divided into 15 eyes each in Group A and Group B. Group A were given intravitreal ranibizumab, and Group B were given intravitreal ranibizumab along with PRP. It is a convenient type of sampling, and duration of the study is 6 months. All the demographic details were collected, and the study was in accordance with the ethical committee guidelines, and all the patients were informed about the purpose of the study, and an informed consent was taken. Institutional review board clearance was also taken. Coming to my methodology, best corrected visual acuity in logMAR format was recorded, and IOP with Goldman appellation tonometry was done. Pupillary dilatation was done with 1% tropicamide eye drops and after checking IOP. Dilated fundus examination with direct ophthalmoscope plus 90D, and in case of media haziness, an indirect ophthalmoscopy was done in these patients. On fundus, diabetic retinopathy severity was graded using EDTRS protocol, and basic blood investigations were performed like RBS and HbA1c. Coming to the procedure, the first group received intravitreal ranibizumab of 0.5 mg in 0.05 ml at baseline 4 weeks and 8 weeks. The second group received standard PRP treatment delivered as per the routine clinical practice, targeting non-perfusion areas along with intravitreal ranibizumab. And PRP was done with a single retinal specialist with Nidec green laser of 532 nanometers frequency. PRP was performed in 2 sessions with an interval of 15 days between 2 sessions, and shots were delivered with a pulse duration of 0.2 seconds for the total of 1200 to 2000 burns. SDOCT was performed using central retinal thickness. Coming to the inclusion criteria, patients with proliferative diabetic retinopathy defined as per EDTRS guidelines as follows: presence of neovascularization at the disc, presence of neovascularization at this associated with vitreous or pre-retinal hemorrhages, neovascularization elsewhere with more than half disc area associated with vitreous or pre-retinal hemorrhages. And my exclusion criteria was significant patients with significant media opacity, any history of previous laser treatment or vitrectomy in the study eye, fractional retinal detachment, patients with history of ophthalmic diseases other than DR and cataract, patients with intraocular surgery except for cataract extraction, and patients with external ocular infections. Coming to the data analysis, it is a type of, it was collected and analyzed in Microsoft Excel and SPSS software, and my main was independent sample t-test, and less than 0.05 p-value was taken as significant. Coming to my results, the p-value in both the groups were, when compared, they were less than 0.05, which is significant. Coming to discussion, compared to other studies like Joss et al., where pan-retinal photocoagulation versus PRP plus PRP with intravitreal ranibizumab for high-risk proliferative diabetic were done, they concluded that intravitreal ranibizumab after PRP was associated with reduction of FLP at the week of 42 compared with the PRP alone. Coming to Joss et al., in which ranibizumab plus PRP was done, is called as Proteus study. It concluded that intravitreal ranibizumab along with PRP were more effective than PRP monotherapy alone. Coming to my limitations, it's a shorter follow-up time period was done, and in conclusion that intravitreal ranibizumab along with PRP was associated with larger reduction in central retinal thickness at 1 month when compared with intravitreal ranibizumab alone in patients with PDR, and the additional use of PRP appears to protect against a visual function than intravitreal ranibizumab alone. These are my references. Thank you.
Okay. So is this an observational study?
Yes, ma'am. Actually, mine was an observational study because I was not suggesting them any treatment.
Actually, this comes under comparative interventional study.
Okay.
Okay. So which one do you think is better now?
Actually, both were giving similar results, ma'am. But if both were similarly done, intravitreal ranibizumab alone will be better because it will be easier for the patient comfort, and it is a single monotherapy, so it's better to opt for
Needs
intravitreal.
longer follow-ups.
Yes, ma'am.
Every month you have to follow up the patient.
Yes, ma'am.
Out of all, how many of the in group 1 patients, how many acquired the laser, post-intervention laser?
Actually, I did a very shorter follow-up period, sir. So, for my follow-up period, we didn't find any extra laser that
Requirement of
needed.
any laser in the group 1?
No, sir. Thank you.
Dr. Nikhila?
Good morning, everybody. Today's my topic is about correlation between glycemic index and retina nerve fiber layer thickness in type 2 diabetes mellitus, a comprehensive study. Introduction. The aim of the study is to generate the data on retina nerve fiber layer thickness in a tertiary care center. It aims to study if there is any correlation between RNFL thickness with blood glucose parameters. Coming to diabetes mellitus endangers sight by damaging the neurovascular system of the eye, including the optic nerve. It's crucial for individuals with diabetes to manage their blood sugar levels, blood pressures, cholesterol, as well as to undergo regular eye exams. Recently, HbA1c measurement is regarded as the gold standard indicator for glycemic control in diabetes. This reflects glucose levels over 2 to 3 months of period. RNFL thickness is the innermost layer of retina and consists of nerve fibers that originate from the ganglion cells. RNFL thickness is found to correlate with optic nerve involvement and visual acuity. Hence, measurement of RNFL thickness is not only a descriptive entity but also used as a predictive parameter. Inclusion criteria: age more than or equal to 45 without clinically significant macular edema, and intraocular pressure below 20 mm of Hg, and also requires a good quality of OCT. Characteristics were recorded including age, sex, type, and duration of diabetes, blood glucose parameters. Exclusion criteria: systemic illness other than diabetes mellitus, any ocular surgery, more than 60 years of age to avoid age-related thinning, previous history of glaucoma, ocular trauma, congenital ocular disorders, or any other neurodegenerative diseases, or any changes in corneal curvature. Materials: RNFL thickness was measured by APOS 2018 IAPB spectral domain with RNFL and ONH with optic disc cube protocol. Each reading was an average of 3 consecutive readings. If any image was found to be distorted, it was rejected and new set of readings was taken. The blood parameters for glycemic status like fasting blood glucose, postprandial blood glucose, and glycosylated hemoglobin was done. Methodology: this was a cross-sectional study in a tertiary care center. The patients were at first explained about the procedure in local language. The ongoing treatment for diabetes was not changed or withheld. The pupils were dilated by topical dilatation drops using 1% tropicamide and 2% phenylephrine for examination. Each eye took an average of 3 minutes, including time for alignment. High-speed image were obtained by resolution of 3 micrometers. A circular area of diameter of 3.6 mm around optic nerve head around 12 degrees was measured for retinal thickness with infrared rays of wavelength 830 nanometers. All the readings were taken by the same person. Each reading was an average of 3 consecutive readings. The actual RNFLT in microns in the 4 quadrants, superior nasal, inferior and temporal, of the circle was given along with the color coding grading in each quadrant. Green depicts normal, yellow depicts borderline, and red depicts thin. So this is the picture of showing the OCT image, where you will have a quadrant images and also seen in clock hours. Results: we had a total of 50 patients, which means 100 eyes, and average age of the participants were 53 plus or minus 8.1 years. Out of 100 eyes, retinal thickness was low, 10%, 95% confidential intervals. The average HbA1c levels in those with lower RNFL thickness was significantly higher than other groups. The average RNFLT around the optic nerve head was correlated with blood glucose parameters. For FBS correlation, coefficient ratio was minus 0.19. for PPBS is minus 0.32, and for HbA1c, which is correlating, is minus 0.46. The cross-sectional study shows that a large number of diabetic patients had thinned out RNFL and blood glucose parameters, has significant negative correlation with HbA1c. The pathophysiology behind RNFL thinning is a multifactorial, and the exact mechanism is still debated. But probable theories include ganglionic cell dysfunction and apoptosis. Chronic hyperglycemia is also said to affect neurons. Chronic hyperglycemia activates lots of metabolic pathways that ultimately lead to activation of nuclear factor kappa B. Nuclear factor kappa B leads to oxidative stress in the retina and damage to neuronal tissue. Metabolites of the retinal angiotensin system, especially angiotensin 2, activates AT1 receptor in the retina and leads to oxidative stress and damage to RNFL. In conclusion, the retina nerve fiber layer thickness as measured by OCT is significantly decreased in diabetes, and this correlates with blood glucose parameters, especially for HbA1c. There is a significant negative correlation. The correlation was also high in all quadrants around the optic nerve head. Strict glycemic control may be an effective treatment strategy to prevent retinal changes and retina nerve fiber layer at early stages. These are my references. Thank you.
So any particular cause for excluding abnormal corneal curvatures in your study?
Like OCT, in case of OCT, if any corneal curvatures also affects, there is a study
Does that affect your imaging
that
of
affects the
RNFL?
imaging of the RNFL.
Okay, so how do you want to explain the patients about the prognosis? I mean, if the RNFL thickness is less, is it going to progress more? I mean, diabetic retinopathy, is it going to progress more?
Yes, it's going to progress, ma'am, but not only that factor, but if the patient is above 60 years, more than age of above 60 years, we will also explain that not only due to the diabetes, but also age-related thinning also exists within, goes simultaneous hand in hand.
Along with diabetes.
Along with diabetes.
What is diabetic papillopathy?
Sir?
Diabetic papillopathy.
In case any papillae, along with the retinal changes, there will be papillae.
Actually, the disc changes present in the diabetes. It's more prominent in is unilateral, and more we can see in proliferative diabetic retinopathy and ischemic maculopathy. Okay.
So without knowing pre-diabetic RNFL thickness, how can we know it is decreased, whether it is
so actually, only thing is we should take a pre also, sir, but only thing is we have taken the studies a cross-sectional study only for the people. Thank you.
Dr. Mohammed?
Good morning. Good morning, everyone. I am Dr. Ahmed from GEMS College. My topic is study on outcomes of intravitreal bevacizumab in treatment of diabetic macular edema. Introduction. Diabetes mellitus is a metabolic disease known in ancient times. Diabetic population in India is thought to be estimated as 69.9 million by 2025 and 80 million by 2030. The global prevalence of diabetic retinopathy and diabetic macular edema were 27% for any diabetic retinopathy, comprising of 25.2% NPDR with 1.4% PDR and 4.6% diabetic macular edema during 2015 to 2019. Diabetic macular edema is one of the major cause of loss of central vision and visual acuity in diabetic patients. Clinically significant macular edema is defined as the retinal edema and hard exudates within 500 micrometers of the center of macula, and retinal edema of 1 disc diameter or larger, any part of which is within 1 disc diameter of center of macula. Up to 10% of all the patients with diabetes will develop diabetic macular edema during their lifetime. The Wisconsin epidemiological study of diabetic retinopathy found the 14-year incidence of diabetic macular edema in type 1 diabetes to be 26%. Prevalence of diabetic macular edema is more in NPDR and increases with the severity. Vascular endothelial growth factor has shown to be critical stimulus in the pathogenesis of macular edema secondary to diabetes. Diabetic macular edema commonly leads to visual loss in the patients of diabetic mellitus, and this loss of vision can be irreversible. Increased in the vascular permeability due to diabetic results in the leakage of fluid in the plasma constituents into the retina, leading to diabetic macular edema. The ETDRS reveals that focal laser photocoagulation plays a beneficial role and reduces the rate of moderate visual loss by 50%. Patients having media opacity like cataract at times make it impossible for the doctor to do complete macular grid laser, so there is need of alternative adjunctive treatment. VEGF was discovered in 1989. Hypoxia stimulates the normal retinal pigment epithelium cells to secrete VEGF. Eyes having diabetic macular edema have significantly elevated levels of VEGF. It is observed that eyes with heavy macular leakage have significantly higher VEGF concentration as compared to eyes with less leakage. Therefore, anti-VEGF treatment can be considered as an adjunctive treatment for DME. Bevacizumab is a full-length antibody that inhibits all isoforms of VEGF-A family. It is licensed by FDA for treatment of colorectal carcinoma. The objective of my study is to study the efficacy and safety of intravitreal bevacizumab in treatment of diabetic macular edema. Inclusion criteria: patients with presence of clinically significant macular edema in both PDR and NPDR with no prior treatment, patients of either gender with any age, duration and level and control and severity of the diabetes, and central retinal thickness on OCT showing greater than 250 microns or presence of cystic spaces, and best corrected vision pre-treatment should be worse than 612. Exclusion criteria: macular edema secondary to causes other than diabetic retinopathy, vision loss secondary to cause other than diabetic macular edema, diabetic macular edema previously treated with intravitreal triamcinolone or other anti-VEGF agents, previous history of focal or grid laser, corneal diseases, inflammatory eye diseases, optic neuropathy and age-related macular degeneration, any ocular surgery in past 6 months, if patient is having uncontrolled hypertension or thromboembolic events or in pregnant. My materials and methods, sir. It is a hospital-based prospective interventional study conducted at GEMS Hospital Ophthalmology Department, Ragolu, Srikakulam. Patients are selected based on the inclusion and exclusion criteria. A total of 27 eyes of 27 patients with diabetic macular edema. Those who are undergoing intravitreal bevacizumab injections for DME were included from January 2023 to July 23. Patients are having either gender and aging between 48 to 70 years. After explaining the purpose and procedure of my study, informed consent was taken. All the patients are examined by me to minimize the bias. Detailed medical history, clinical examination, which includes visual acuity, slit lamp examination of the anterior segment and posterior segment using 90D lens, posterior segment examination by indirect ophthalmoscopy using 20D lens. A baseline OCT was done on upper swami OCT 2 days prior to procedure. Intravitreal bevacizumab injection 1.25 or 0.05 ml was injected 3.5 to 4 mm from limbus infratemporally under topical anesthesia. Post-procedure antibiotic eye drops were instilled 4 times a day per week. All the patients were treated with 3 injections of Avastin with a time interval of 1 month between each dose. All patients included in the study were assessed preoperatively for visual acuity and central macular thickness. After the first dose of injection, patients were examined on post-procedure day 1 and follow-up monthly for 3 injections. Statistical analysis was performed using SPSS software. Results: the mean age of the patients in my study was 58 years. All the patients were diagnosed as type 2 diabetes mellitus. Mean duration of diabetes in my study was 11.25 years. All the patients were treated with 3 injections of bevacizumab and at 1 month interval for each injection. Visual acuity and macular edema were evaluated monthly and prior to procedure and follow up until 3 months. In our study, a sample of 27, male are dominant than females, 74%. Laterality of the eye is right eye is more than left eye. And type of diabetes are moderate NPDR are 38% and severe NPDR 50%, very severe NPDR are 4% and PDR are 8%. Comparison of visual acuity before intervention and monthly follow-up. Best corrected vision less than 660, I have 7 patients, and from 636 to 624 we have 9 patients, 618 to 612 we have 11 patients pre-operatively, a total 27. After first month of injection, the visual acuities are gradually going better, that patients were reducing from 660, the number of patients from 660 are reduced to 3, and later after first month after second injection they were reduced to 2, and first month after third injection they were reduced to 1, with a p-value significant with a p-value of 0.03 and 0.01, less than 0.01. The mean comparison of logmar units of BCVA pre-intervention and post pre-intervention and monthly follow-up. Pre-intervention, there are 7 patients with logmar unit 1, and mean logmar units is baseline mean logmar is 0.67 plus or minus 0.3, and after 1 month after first dose the baseline was the logmar value was 0.48 plus or minus 0.28. 1 month after the second dose the logmar was 0.43 plus or minus 0.
Sorry to intervene, I think time is already over. Can you conclude at least? Go to the conclusion. made your conclusion?
There is significant reduction in central macular thickness at the end of follow-up as compared to baseline, and significant improvement in BCV at the end of follow-up as compared to baseline. And there are no complications at the end of my study. This says the bevacizumab is safe and effective. Thank you.
Dr. Naini? Dr. Ravi Naini? No? She is not there? No, she is not Naini. You are Ravi Naini. It came wrong. Okay. So you are? So how come? Author is wrong. Should be one of the- Dr. Lechna will present. Come.
Good morning, respected teachers. Myself, Dr. Lechna, presenting a rare case report of Vogt-Koyanagi-Harada disease with Hashimoto's thyroiditis. VKH disease is bilateral granulomatous pan-uveitis associated with serous retinal detachment with or without extraocular manifestations affecting young adults. In 1932, Bebel suggested to call this entity as VKH disease. It is a T-cell driven autoimmune reaction associated with HLA-DR1, DR4 of subtype 0405, and it presents in three forms: complete, incomplete, and probable VKH. My case report: a 20-year-old female whose occupation is student came with a chief complaint of defective vision in left eye since 3 days and headache since 1 week. Defective vision in left eye is sudden in onset, not associated with pain, redness, photophobia. No history of floaters, no history of ocular trauma, ocular surgery, or ocular infection. No history of photopsia, micropsia, macropsia, or metamorphopsia. Headache which is bilateral frontal, not associated with nausea, vomiting, or reeling sensation. No history of tinnitus and hearing impairment. Past history: there is history of prodromal illness 5 days before defective vision associated with headache, orbital pain, light sensitivity, and mild fever. She is a known case of hypothyroidism on tap thyroxine sodium. Personal history, family history, or nil significant. Menstrual history: she is a known case of PCOS. General examination: no signs of meningismus, no signs of alopecia, vitiligo, poliosis. Vitals and systemic examination are within normal limits. Local examination also within normal limits. On ocular examination, I'll come to positive findings. In both eyes, uncorrected visual acuity is 612 parts, not improving with pinhole. Near vision is N6 and color vision is 17/17. Apart from cornea showing fine pigmented capes in a vertical line and AC showing grade 1 cells, rest all anterior segment findings are within normal limits in both eyes. IOP with GAT recorded at 11 AM in right eye to be 12 and left eye to be 10 mm Hg. Fundus evaluation with IVO and 90D in both eyes showed media clear, optic disc normal, and serous macular detachment with dull foveal reflex in both eyes. Here is the fundus image of both right and left eye showing a serous macular detachment in both eyes. Based on the above clinical findings, we came to a provisional diagnosis of probable VKH disease with hypothyroidism query Hashimoto's thyroiditis. On further clinical evaluation, we have done OCT macula, where in both eyes showed multiple pockets of subretinal fluid suggestive of neurosensory retinal detachment with RPE alteration and choroidal thickening. And fundus fluorescein angiography in both eyes showed early hypo with multiple pinpoint hyperfluorescence with RPE alteration establishing our diagnosis. B scan of both eyes showed increased choroidal thickening. Her TSH is also elevated, showing 10 micro international units per ml. Adding to it, her anti-TPO antibodies were also elevated, 6.9 international units per ml, whose biological reference value is less than 5.61, suggestive of Hashimoto's thyroiditis. To exclude other autoimmune etiologies, we have done ANA, which came out to be weak positive, showing 1:40 sample dilution. Her ESR is also elevated. She was treated with both eyes periocular triamcinolone acetonide injections along with systemic tab prednisolone 60 mg OD with Pantop, calcium, vitamin D3 and thyroxine sodium 50 micrograms once daily, regular TSH monitoring. Referral has been done to ENT and dermatology departments to exclude possible hearing impairment, where Pureton audiometry came within normal limits and dermat no integumentary signs were noted. Review after 1 week, her visual acuity in right eye improved to 6.9 parts and left eye it is 6.6 parts. Simultaneous OCT here, if you see, this is pre-steroid injections macula status and this is post-steroid injections. All the subretinal fluid got resolved and RPE changes still seen in both eyes. Review after 1 week, there is modification in the treatment regimen. Tab mycophenolate mofetil 500 mg OD is added the following week in combination with oral steroid, tapering 5 mg weekly. Here if we see tab MMF, it has been seen in incremental dosage from OD to TID, while steroid dose has been tapered from 60 to 45, tapering 5 mg weekly. Currently she is on tab prednisolone 10 mg once daily and tab MMF 500 mg TID along with thyroxine sodium 50 micrograms OD with TSH under control and regular follow-up. Coming to discussion in our case, good visual acuity is achieved by early diagnosis with OCT FFA followed by aggressive therapy with periocular and oral steroids in acute uveitic stage and maintenance therapy with a combination of both steroid and antimetabolites. MMF being safe and effective steroid sparing drug, it is a preferred antimetabolite in combination with steroids on long-term treatment as it prevents progression of VKH to chronic recurrent stage. Diagnosis of Hashimoto's with positive anti-TPO antibodies, exclusion of other autoimmune disorders like lupus choroidopathy with negative ANA and referral to ENT dermat departments for evaluation of extraocular manifestations is important in our case management. Conclusion, visual prognosis depends upon early treatment with steroids and immunosuppressants that results in fair prognosis with 60 to 70% retaining vision 6/9 or even better as achieved in my patient. Prevention of recurrence leading to choroidal neovascular membrane and subretinal fibrosis is important in order to restore good visual potential. My case highlights the importance of management and evaluation of VKH in detail to find out any other associated autoimmune disorders like Hashimoto's that lead to serious systemic complications like heart failure, lymphoma, etc. These are my references. Thank you.
Okay, what are the features supporting your diagnosis? Why do you say it is VKH syndrome?
Ma'am, there is posterior uveitis bilateral presentation as well as there are multiple serous retinal detachments with AC cells and flare, and our fundus fluorescein angiography also suggests early hypofluorescence and multiple pinpoint leakage points.
Bilateral serous detachment is
yes,
your actual finding.
Yes, ma'am.
But the skin lesions and all, they were not there.
This is a probable VKH where we see only bilateral ocular manifestations without any neurological or integumentary
was
findings.
Not there in your case.
Yes,
but this was the first presentation?
Yes,
according to the patient.
Yes, ma'am.
So this was not the recurrence also?
No, ma'am.
First time the patient is presented.
We have early diagnosed and we are preventing further its progression.
Why did you treat with periocular steroids instead of systemic steroids?
Periocular steroids will decrease the local inflammation and relieve her from the illness. Systemic steroids also, she is kept on systemic steroids along with periocular steroids. Yes. Yes. She is 20 years.
Did you give vitamin supplements along when you start with steroids or immunosuppressants? Vitamin supplements.
Yes, sir, immunosuppressants.
Vitamin supplements.
Yeah, we have given vitamin D3, calcium, pantoprazole. And
Risk of
regular
cataract.
CBP monitoring, evaluation of cytopenia, any elevation of transaminase, we are regularly monitoring her liver function test as well, sir.
20 years
reduce
also
the
is
local
too early
inflammation
to start
steroids.
on immunosuppressants. I mean, she has not even completed the family. We need to take a big decision to start on immunosuppressants.
This is a preferred one, ma'am. and she is also counseled on long. Otherwise, she would land in pan-uveitis, smoldering pan-uveitis in recurrent states. Thank you.
Dr. Roja.
Good morning everyone, I am Dr. Roja. I am going to present a case of bilateral retinal venous occlusions, ischemic CRVO left eye, BRVO right eye, secondary to primary angle closure, a rare case report. Introduction. Retinal vein occlusions with CRVO or BRVO results in rubeosis iridis and neovascular glaucoma. CRVO is either ischemic or non-ischemic. BRVO is a blockage of tributaries of central retinal vein. Serous macular detachments are common with ischemic CRVO. Primary angle closure with raised IOP as a precipitating cause is a rarity, with associated hypertension, nephropathy and anemia being risk factors. PAC or PSEG can cause mechanical displacement of the main venous trunk, leading to stretching, weakening of the vein wall, and compression, collapse of the vein, leading to venous stasis and obstruction of the central retinal vein. A 53-year-old female came with the complaint of defective vision in left eye 2 months, headache 1 month. History of presenting complaint, defective vision in the left eye 2 months, sudden onset, headache not associated with vomitings, and no other positive history. Past history, history of hypertension since 2 years, not using any medication. Personal and family history nil significant. General examination, anemia is present. Vitals, blood pressure is 180 by 100 mmHg. Systemic examination and local examination is normal. Ocular examination, right eye, uncorrected visual acuity 6 by 36, best correction 6 by 6. Anterior chamber quite shallow, VH grade 1. Lens early IMSC, IOP is 18 mmHg and rest all anterior segment findings are normal. Left eye uncorrected visual acuity 2 by 60 with best correction not improving. Anterior chamber quite shallow, VH grade 1, pupil RAPD grade 1, lens early IMSC and IOP is 40 mmHg and rest all anterior segment findings are normal. Indentation gonioscopy, both eye angles are narrow, no signs of neovascularization. Fundus examination of right eye, media is hazy due to cortical opacities. OD, temporal pallor is present, AV ratio 2:4, venous engorgement is present, foveal reflex is present, peripheral retina, superficial flame-shaped hemorrhages present along the superior temporal vascular arcade with cotton wool spots. Remaining peripheral retina is normal. Fundus examination of the left eye, media is hazy due to cortical opacities. OD is hyperemic, edematous, physiological cup obliterated, blurring of margins present, elevation of the disc 1 mm, AV ratio 2:4, venous engorgement is present, foveal reflex is absent, macular edema is present, peripheral retina, multiple superficial hemorrhages present all over the fundus with some cotton wool spots in the peripapillary and macular area. On above clinical findings, my provisional diagnosis is ischemic central retinal vein occlusion left eye, superior temporal branch retinal vein occlusion right eye, secondary to primary angle closure both eyes with immature senile cortical cataract both eyes. On further evaluation, OCT of left eye shows serous macular detachment and OCT of right eye is normal. Patient is managed with brimetoprost, acetazolamide and NSAIDs for 3 days. Both eyes laser peripheral iridotomy was done and IOP reduced, right eye 12 mmHg, left eye 10 mmHg. Intravitreal ranibizumab injection was given in left eye and after 3 doses of anti-VEGFs in left eye, visual acuity improved from counting finger 2 meter to counting finger 5 meter and IOP is maintained. Fundus and macular status post anti-VEGF agents in left eye. After first dose, there is resolution in the retinal hemorrhages in the right eye along the superior temporal arcade and resolution of the retinal hemorrhages and exudates in the left eye. Now OCT shows resolving macular edema. After second and third dose, there is further resolution of the retinal hemorrhages and exudates in both eyes and resolving macular edema. OCT angiography of left eye shows enlargement of the foveal avascular zone and capillary non-perfusion areas, whereas right eye is normal. And ERG shows loss of oscillatory potentials in the left eye and right eye is normal. As the patient is having systemic comorbidities, the following systemic investigations are done. ECG shows left ventricular hypertrophy changes, 2D echo ejection fraction is 57%, serum creatinine 2.5 mg per dl, HB 7.6 gram%, peripheral smear shows anemia with eosinophilia, lipid profile is normal, ultrasound abdomen shows bilateral grade 3 renoparenchymal changes, HB electrophoresis is normal, sickling test is negative. And patient was referred to general medicine and nephrology and the following treatment was advised. Discussion. Ischemic CRVO leading to neovascular glaucoma is a serious complication with comorbidities like hypertension, nephropathy, anemia and cardiac dysfunction. Primary angle closure disease with acute attack acts as an important risk factor for precipitating CRVO, as we have seen in this case. Chronic kidney disease leading to hyperviscosity and anemia are additional risk factors for precipitation of CRVO in our case. Conclusion: bilateral retinal venous occlusion, CRVO left eye, BRVO right eye, with serous macular detachment in left eye secondary to PAC is a rare entity which is highlighted in this case. Thorough evaluation of the angle of the anterior chamber by gonioscopy, IOP monitoring in patients with comorbidities will avoid such complications as CRVO, which can lead to neovascular glaucoma. Treatment of comorbid conditions like anemia, hypertension, nephropathy are important in the management. Thank you.
Presentation. So did you do any laser for the right eye?
Yes, ma'am. Both eyes laser peripheral iridotomy was done.
So that was done.
Yes,
And the patient is being followed up.
Yes, ma'am.
Till now the patient is fine.
Yes, ma'am.
What can be the hypothesis behind the primary angle closure causing bilateral occlusions?
Primary angle closure is a risk factor for central retinal vein occlusions, sir. Maybe phacomorphic component may also be present as the patient has IMSC also.
Have you done carotid Doppler in this case?
No, sir. As the patient has many comorbid conditions, so we deferred that. Thank you, sir.
Good morning everyone. I'm Dr. Pravalika, second year postgraduate. Today my topic is quantitative monitoring of papilledema evolution using spectral domain optical coherence tomography. Financial interest nil. Introduction: papilledema is defined as an optic disc swelling that is secondary to the elevated intracranial pressure. Papilledema usually presents as a bilateral phenomenon and may develop over hours to weeks. Early diagnosis of papilledema can help in early intervention and thus preventing the vision loss and even death. The main objective is to evaluate the role of retinal nerve fiber layer thickness during papilledema course. Study methodology: the study design, a hospital-based prospective observational study, sample size 28, study place Department of Ophthalmology, Jimsar, Visakhapatnam, study period from September 2022 to June 2023. All subjects underwent detailed opthal examination including refraction, color vision, slit lamp examination for anterior segment and fundus examination. Average RNFL thickness measurement with SD-OCT. After treatment, follow-up was done at first and third month for papilledema patient, and there was no follow-up for the controls. Patients between 8 to 50 years of age with papilledema are included as cases, and healthy volunteers between 8 to 50 years of age who do not have any signs of papilledema and no neurological disorders or other systemic illnesses were included as controls. Exclusion criteria: patients with the neurologic disorders other than papilledema, patients with media opacities such as corneal opacities, vitreous hemorrhage and cataract are excluded, and patients who did not give consent were excluded. Results: the gender distribution shows males are 43% and females 57%. This is the fundus picture and the OCT picture at the first visit. The fundus picture of a patient shows media is clear, the disc is hyperemic with edema, blood margins and tortuous vessels, and the FR is present, and the OCT shows the total RNFL thickness in the right eye shows 185 and the left eye shows 195. This is the fundus photo and the OCT picture at second visit, that is after 1 month. There was a resolution in the fundus, and the RNFL thickness shows 145 in the right eye and 161 in the left eye. This is the fundus picture and OCT at the third visit, where the RNFL thickness shows 108 and 105 in the left eye. Fundus picture and the OCT for the controls, where the RNFL thickness was 101 in the right eye and 107 in the left eye. Distribution of the mean RNFL thickness for the cases shows in the first visit the mean was 175, and in the second visit it was 145, and in the third visit it came to be 110. This is a table showing the distribution of average RNFL thickness for the cases and controls. So the first visit is 174 plus or minus 20.5, and in the second visit it is 145.6 plus or minus 14.2, and in the third visit it is 114.8 plus or minus 12.3, and for the controls it is 101.7 plus or minus 6. So the mean difference was when compared to the first visit, the mean difference was 72.9 plus or minus 12.4, and in the second visit it is 43.9 plus or minus 16.2, and in the third visit it was almost similar. So the mean RNFL thickness was 71.68% greater than in the control eyes. At first follow-up visit, the mean RNFL thickness was 43.16 greater than in the control eyes. Among 14 patients, RNFL thickness normalized, but in one patient it was progressing even at the third month follow-up. Our study emphasizes the role of SDOCT in diagnosis and monitoring of papilledema in a Visakhapatnam population. So these are the studies who has conducted a cross-sectional study which included 24 subjects and 22 controls, and they showed that average RNFL thickness will be decreasing in the subsequent follow-up visits. And there's one more study, Ahuja et al., who conducted a case control study and has taken 100 cases and 126 controls and concluded that the positive correlation was found between Frisson grading of papilledema and the RNFL thickness measurement. Panyala R et al. Conducted a cross-sectional study from December to June, and he has taken 30 papillitis and 30 papilledema and 30 controls, and he has concluded that the RNFL thickness normalized at 3 months of follow-up, and the RPE Brooks membrane angle progressively decreased but normalized at 6 months of follow-up. So my conclusion is the data support the possible use of SDOCT as a non-invasive quantitative method of monitoring the amount and the evolution of the papilledema. These are my references, and thank you.
Good presentation.
We have finished our session now. All are very innovative concepts. Thank you for the cases.